Come in.
Hi.
Ms. Nichols?
Yes.
Hi. I'm Kelly. I'm a medical student. So what brings you to the office?
Well, I'm pregnant. And
Congratulations.
Thank you. And I know that I'm a little older. I'm 38, and my husband and I have been talking about it. I've been reading a lot on the internet, and I just know there's testing and there's other things that can be done, and I don't know if I should be worried about getting certain tests or genetic things done, and
Sure.
I just need some advice.
Okay. Is your husband here with you today, or?
No, he couldn't come today.
Okay. Well, we'll talk about it in here, and then when we're done, I'll give you some handouts too that you can take home with you since he couldn't be here.
Okay.
So you can have the information as well.
Okay.
So first off, what have you been reading on the internet, and what are you kind of concerned about?
Well, I think the first thing that I'm concerned about is that they say if you're over 35, then you're at risk for all of these kinds of birth defects and Down syndrome and stuff, and that there are tests to determine some of that,
Sure.
but maybe they don't always work and things. So
Sure.
I guess I just need to know, am I supposed to get all these tests? What am I supposed to do?
Well, so let's start off with the risk part. So that is correct that you are at risk for having a child that has Down syndrome or possibly other anomalies. That's not to say that's going to happen, but the risk does go up as you get older. So we do have some tests. Some are non-invasive things, things that don't hurt at all, things like an ultrasound, and some are blood tests. And they're done at different stages of the pregnancy, so it kind of depends on how far along you are. But they can basically give us an estimation of how at risk your baby is for having these complications. They won't tell us for sure one way or the other. You certainly don't have to have them if it's something you're not comfortable with and you don't want to know. But if it's something you do want to know, and you want to make decisions about the pregnancy based on those tests, we can certainly do them.
Okay.
Do you think you're interested in doing any of those tests?
I think, yeah. I definitely want to know
Okay.
if something's maybe not right.
Okay. Do you know how far along you are in your pregnancy?
About 10 weeks.
Okay. Some options we do have. We'd first start with something non-invasive, not go straight to the blood test. So we can do an ultrasound to look at baby, and like I said, that won't completely give us the answer, but it could tell us if your baby's at increased risk. And we kind of look at how baby looks swimming around, and we look at the baby's neck, and we look fingers and toes and things like that. We look at the baby's heart. So that would probably be the first thing we would do, but it's a little early right now, obviously, to do that. So,
okay.
But if you did want to do some of the other blood tests and some of the more invasive tests, we have to do them early on in the pregnancy. So I guess the ultrasound, wouldn't be the first thing we do. We do that a little bit later because baby's still small in there right now.
Okay.
So we do the blood test, and those do come with risks. They can pose risks to the baby, but you have to decide kind of if that's something you want to do. We do have that is an option. We can proceed, and I can go through all the benefits and risks of the procedure.
Okay.
But basically, what that tells us is we look at a couple hormones and a couple levels of things in the blood, and it'll tell us, like I said, if you're at increased risk.
Okay.
Do you have any other questions about that? Or?
Well, one of the things that I read about, and I can't remember what, but they kept saying like trisomy.
Sure.
And there were different numbers, and it sounded like some were okay and some weren't okay, and some really weren't okay. Can you tell me a little bit more about those?
Sure.
Those things I'm at risk for? Sure.
So a trisomy basically refers to the number of chromosomes that baby has. So you have a certain number of chromosomes, and if you have more than one copy of some of those, or 3 copies, like a trisomy, baby can come out with some defects. So Down syndrome is actually a trisomy. It's trisomy 21, meaning that there's 3 of chromosome 21. So, and there's not a quiz or anything that's not important to remember, but basically that, and that causes the problems in babies, so having too many of those chromosomes. There's also trisomy 18, and that can also result in some defects in baby. And yes, you're correct, some are worse than others. Sometimes when babies do have a trisomy, they don't necessarily all look the same, so they don't have all the same features, meaning some people have trisomy 21 and are a certain way, and some people have trisomy 21 and can't function as well as another person. So they are affected differently is what I'm trying to say. Does that make sense?
Sure.
Okay.
Sure.
So there's trisomy 21, trisomy 18, and there's some other defects that baby can have, such they're called neural tube defects. It's basically just refers to the spinal cord and whether or not have you ever heard of spina bifida at all?
Yes.
Okay, so whether or not the spinal cord closed correctly.
Okay.
So those are just a couple of the things. Have you been reading about those online, or?
I think I just knew, like, some of them were, they said the baby couldn't live.
Sure. And there are some trisomies that aren't compatible with life. So if the baby did have 3 of a certain chromosome, they wouldn't survive. Trisomy 18 and trisomy 21 are compatible with life, but obviously they would have some defects. So some malformations, which could be, just in the way they look, it could be in their heart. There's several things associated with that.
Okay.
So.
A friend of mine told me there was something like a free DNA test that you could have. Do you know about that?
I've heard of it, but I'm not really sure all the details, but I could get you some more information on it, and certainly get you some to take home to give to your husband as well. So.
Okay.
But I would have to see about that. So.
Okay. And you mentioned that, like, some of the tests later on are more invasive?
They are. They involve sampling some of the amniotic fluid, which is what baby's swimming around in. So we would have to stick it's essentially a needle, it's very small, but we would have to stick that into the belly, which it's not too painful, but because it's a very small needle, but we would have to stick a needle into the belly and take some of that fluid, and some risks, obviously we could potentially hurt the baby with the needle, but we do it looking at an ultrasound so we can see where baby is, and we're very careful with that, but certainly that is a risk to the procedure. So.
What kind of, it's a risk, what happens?
Well, if, in worst case scenario, it could be loss of the pregnancy, but if the needle, were to hurt the baby and maybe we can't see it on ultrasound and there was some bleeding or something like that, we would, that could be a risk to the procedure. But
have you ever seen that happen?
I personally haven't seen a lot of these, so I'm not sure, but from what I understand, the risk isn't that high because of that ultrasound guidance that we use. So because we can see right where baby is. So.
Okay, that's good. Are there other invasive tests or anything that I should worry about? What if I wanted to do everything possible? Every kind of test. What other tests would there be?
Those are the tests that I'm most familiar with. I'm sure there are several others, but I would have to kind of get some more information on those and get that to you.
Okay.
But those are the most commonly used tests and kind of the tests I'm most familiar with.
Okay.
So,
come in.
But do you have any other questions for me today?
So no, that's helpful actually.
Okay.
So thanks, I appreciate it. Okay.
All right. Well, thank you.
Thank you very much.
I'll be in just one second, okay?
Okay.
Just sit tight for a second.
Okay. Yes.
Kelly, how are you?
Good, how are you?
Good. How do you think it went?
It was okay. I mean, I felt comfortable talking to her and everything. I just didn't feel comfortable answering some of the questions.
I think we all agreed that your bedside manner and the way you talked to her was very, very good. And this is meant to kind of be formative in the sense that we want to teach you how to do this. And I think once you get the basic facts and knowledge down, but I think you did a really good job. So I'm just going to go kind of point by point, just kind of highlight some things to take away. The patient came in, she was anxious, and she was fairly highly educated in the sense that she did her homework. But I think when you counsel patients about their age-related risk, it's good to make sure you kind of categorize things in a way that's understandable to the patient. And the way I kind of think about trisomies, I kind of divide them 13 and 18 together and 21 together because they're very, very different.
Sure.
One of the things that you said about compatibility of life, and really 13 and 18, yes, there can be live-born babies, but they're typically not long-term survivors. So in talking about that, I think it's important that the patient understand the reality of 13 and 18 in the sense that most babies that are live-born don't survive for very long, but there are long-term survivors, and most people would categorize those two trisomies as very severe in the sense they typically have heart defects, other birth defects, severe mental retardation, developmental delay, and don't usually survive the first year of life. As opposed to Down syndrome, where there's a high rate of IUFD, fetal demise. Some babies don't survive that are live-born, but a majority of them do, especially those that have correctable heart disease and other things. But the thing that I concentrate on Down syndrome is the spectrum, and I think you touched on that, that not every child or person with Down syndrome is the same. Some are very independent, high-functioning, and some are dependent on, and that's what makes Down syndrome counseling a little bit more difficult. There's some medical problems that are associated with it, heart disease, GI tract anomalies, early Alzheimer's, shortened lifespan. But again, I think that sometimes is harder to kind of condense down to a way that's, that the spectrum is such that it's kind of hard for a patient to understand the whole spectrum of the disease. You did a good job describing the integrated screening. The way I think about integrated screening is there's first trimester options and second trimester options. They can be combined in different ways. And, for this scenario, we just want to make sure you touch on our options. And depending on where you work, could dictate which tests are available. When you talk about it, I think you start off by saying, it's not a risk to the baby, which is the benefit of screening, is that it doesn't pose a loss of procedure-related pregnancy loss. But the downside is there's somewhere in the neighborhood of a 5 to 8% false positive rate. And you did touch on the fact that it can kind of tell us whether to be worried or not. The other nice thing is it actually puts a number on it. It'll say there's a 1 in 600 risk or a 1 in 1,000 risk. The other thing that I usually touch on is that just because that test is negative doesn't mean everything is okay with the baby, because it may have missed a baby with Down syndrome or trisomy 18. And there's a lot of other things that aren't picked up by any test that we do, whether it's an invasive test or a non-invasive test. You touched a little bit on the role of ultrasound, and the way that I would suggest you present it, again, it's the same way as screening. There's first trimester options and there's second trimester options. The first trimester option would include doing a nuchal translucency, nasal bone. The second trimester, the genetic sonogram, looks at the heart, the kidneys, the stomach, the length of the long bones, the humeri, and the femur. Also looks at the nasal bone to try to give us a risk adjustment from the serum integrated screen or whatever risk they came into the sonogram with. You did a good job talking about neural tube defects. Both the second trimester serum screening and the ultrasound are very good, with detection rates approaching 95 to 98% with the combination of those two things together. One thing that I would add when you talk about flipping to the other side of invasive testing, to make sure that you explain there's, again, first trimester options and second trimester option. There's the chorionic villi sampling where there's placental biopsy versus an amniocentesis. And the risk is in the same ballpark. I typically would counsel a patient the risk of loss with the CVS is about 1 in 200. Risk of an amnio is about 1 in 300 to 1 in 500.
Okay.
And that varies, but outside of that, the risks to the mom and baby are very, very small. We do everything under ultrasound guidance, and the overall rate of fetal or maternal injury is very low.
Okay.
And I usually, to be honest, I kind of maybe lightly touch on that.
Sure.
And just, really concentrate more on the procedure-related pregnancy loss, and the fact that we do it under ultrasound guidance to minimize the other risks that we talk about. One thing that is always important when you talk about any of this testing is none of it's perfect. Even an invasive test is not 100%. And there's a lot of things like autism, metabolic conditions, other gene defects that we're never going to detect with modern-day testing. And it's important to understand that a patient can do every test we have available and still have a baby with an anomaly. It's estimated that about 3% of all babies have a birth defect, and then there are specific rare conditions that we are never going to detect with ultrasound or testing. She asked the question about free fetal DNA testing, and again, that's a very new technology. We're still trying to define how that's going to be used. It falls somewhere probably in between screening and an invasive test, in the sense that it's still not, even though it does give the suggestion of Down syndrome or one of the other trisomies, it's not diagnostic. It's not called diagnostic. The detection rate is in the mid-90s to up to 97% detection rate. So it's a very good screening test, but it's very, very expensive. So again, I wouldn't expect you to know about it, but again, it's something that probably over the next few years we're going to incorporate how to use that in the clinical setting. One thing that I think you did really, really well is you were very non-judgmental, non-directive in the way that you counseled her, and that's the way that I do this counseling as well, to make sure that they never feel that you're biased one way or the other, that they never feel pushed one way or the other.
Sure.
And certainly when you're talking about things like pregnancy termination, deciding to do tests that put a pregnancy at risk, you never want the patient to feel that your bias is pushing them one way or the other, and you certainly don't want to make them guilty about the decisions that they make. So overall, I think you did a really nice job, and again, your approach to the patient was spot on. And again, as you build a knowledge base, it'll get smoother and smoother. And go from there. Do you have any questions for me?
I don't think so. I think, I think the only reason it felt more difficult is because I didn't know, some of the basic knowledge, but it felt easy to talk to her and everything, so.
All right. Well, good job.
Okay, thank you. Do you need this back?
Actually, that's not the answer sheet.
Oh, okay.